And welcome to the Encephalitis Podcast. My name is Prav and I'm from Encephalitis International. Today, we'll be talking about clinical trials in pediatric autoimmune encephalitis. To learn more, I'm grateful to be speaking to Dr. Melissa Wright. Dr. Wright is a pediatric autoimmune neurologist at the University of Utah and serves as director of the Paediatric Autoimmune Neurology and Neuroimmunology program at Primary Children's Hospital. She completed medical school and child neurology residency at the University of Utah, followed by fellowship training in autoimmune neurology. Her clinical and research efforts focus on improving the diagnosis and care of children with neuroinflammatory conditions, including autoimmune encephalitis. Dr. Wright, welcome to the Encephalitis Podcast. How are you doing?
I'm doing well. Thank you so much for having me. I'm really excited to be here today.
Me too. Just to kick things off, what is the need for clinical trials specifically for children with autoimmune encephalitis?
I think to really understand that question, there's two parts to discuss. So the first is why we need clinical trials in autoimmune encephalitis in general. So when we talk about clinical trials are sort of our highest level of evidence that we're able to obtain in understanding how treatments affect outcomes and how treatments affect, safety and things like that. So when we talk about what evidence we have currently in autoimmune encephalitis, we're really drawing on what we call retrospective studies. So, retrospective studies are studies that look back at patients. So, we're looking back at a group of patients who receive specific treatments with a specific diagnosis, and that allows us to make some associations. So we might associate certain medications with certain outcomes, but we can't really determine that cause and effect because there's so many variabilities that we can't control because we're looking back at these patients. So there might be variability in terms of dosing, timing, how many immunotherapies a patient's received at, even one time. And so it's really challenging for us to tease out some of those variabilities. So that's why clinical trials are needed just in general in autoimmune encephalitis. There's so many other variable factors at play that clinical trials allow us to prospectively look at patients, meaning that we enroll them and they undergo specific treatments, and we watch those outcomes sort of in real time unfold. And so there's more control of some of that variability that we see. So in general, that's why we need clinical trials in autoimmune encephalitis. But to answer your question specifically about children, that just sort of adds another layer of need. So in pediatrics, we like to say a lot, kids are not just little adults. It's not the same. There's a lot of different factors that are unique to children in terms of thinking about their disease presentation, their immune system and the way that it functions, dosing of medication even, or how the medication works, sort of what we call the pharmacokinetics of medications in pediatric patients. So, and then even thinking about developmental outcomes, so there's a lot of different factors that are really needed to be evaluated in pediatric patients to understand. So in my field, it's hard to do clinical trials in pediatric patients. There's a lot of added, regulations that we need. And so sometimes I'm left using data from adult studies just in general and applying it to pediatric patients. But I'm left with a lot of questions of, what are sort of some of the more specific concerns? Are there age-specific variabilities that I don't know about yet, that we don't know about yet, that might influence the way that we treat patients? So it's really essential to be able to study these patients in all ages so that we're knowing how it might uniquely affect different patient groups.
Amazing. Yeah, thank you for that general answer. And going into specifics, what would you say is the current state of treatment management for autoimmune encephalitis in children?
It's very similar to the state of treatment in adult patients. Even though I mentioned there's some specific differences in children, the general state of treatment is very similar in that our mainstay of treatment is immunotherapy still. So similar to in adult patients, our typical approach is first line immunotherapy with steroids and immunoglobulins, and or plasmapheresis or plasma exchange. And then for some patients, we go on to second line immunotherapies with medications like rituximab and cyclophosphamide. And that's based on those retrospective studies that I mentioned, sort of our clinical experience, expert consensus. So, although I feel like we've made strides in having more patients receive immunotherapies and receiving them early, there's still some variability in treatment approaches, even though we have some expert consensus guidelines that often we use to sort of guide general management approaches. There's still variability in terms of exactly timing of therapies, dosing, other factors that might vary from institution to institution or provider to provider, because we still don't have FDA-approved therapies specifically for pediatric autoimmune encephalitis here, and we still don't have those clinical trials to guide it. We're entering that age, so it's really exciting because we do have prospective randomized control clinical trials in autoimmune encephalitis now, and actually two that enable children to enroll down to the age of 12, which is really, really exciting for the field.
Absolutely. And we're going to be talking about Extinguish, one of the trials later on in the podcast.
Yeah.
But before that, you have mentioned that children are often treated with therapies that were studied and approved only in adults. So from your perspective, how does that limited evidence shape the way you weigh risks and benefits?
Yeah, I think it's really it adds a different layer of complexity to the conversation. I tend to be very upfront with families about where the evidence is, and I think that sometimes as physicians, we want to give really definitive treatment approaches. We want to be confident. We want to say this is the exact medication that we need to use. But I think families actually appreciate the discussion of uncertainties. I think they really appreciate when we have a full discussion about the risks and benefits. And I talk to them about where the evidence is in pediatrics, where the evidence is in adults, and where we are in that spectrum. And I think it's a more nuanced discussion of here are the risks and benefits, here are the knowns and unknowns, but this is why I'm recommending this specific treatment. And I think families value that approach, of knowing, because they're feeling that uncertainty. They know their child has this disease that is so rare, no one's ever heard of, and I think they know that inherently there's going to be these uncertainties. So I think embracing it in discussions together is they seem to value and appreciate that. So that's one of the ways that I approach it.
Amazing. Yeah, I'm glad you mentioned families because that brings me nicely to my next question, which is that one of the most common worries that families raise about trials is the possibility that their child could receive a placebo, which can feel frightening when the child's seriously ill. How do you talk families through that?
That's a very understandable and reasonable concern for families to have. The first thing that I do is really try to discuss that. I think there's this idea that placebo means no treatment. And what I really discuss with families is that um, this is not what this means for these trials that we're doing, is that placebo, we're not trying to evaluate whether patients need immunotherapies or not. We know that they need immunotherapies. We have enough from those retrospective studies to support the use. We wouldn't want a trial where a patient is getting no treatment at all. What we're really trying to look at, if there's specific treatments, specific immunotherapies, specific approaches that might improve outcomes. So I talk to families very clearly about, first of all, the timeline of the disease, sort of the natural course, and when patients do receive immunotherapies, how long it takes for those immunotherapies to be effective, what immunotherapy approaches we typically take, and how those patients for these clinical trials still receive those first line immunotherapy. So it's not that they're not receiving these, it's that after those first line immunotherapies, they may receive this investigational drug or a placebo. Oftentimes, it's helpful for me to even draw out timelines and the duration that immunotherapies are in effect for, because I think it's very different as well with immunotherapies and autoimmune encephalitis. usually these patients have been previously healthy and maybe their parents have taken them in for an ear infection or something, to their primary care doctor, and they're given an antibiotic, and within 24 to 48 hours they're feeling better and they're back to their normal selves. And then, then they stop the medication after a week and they know everything's fine. With autoimmune encephalitis, we know that's not the case. That even after starting steroids, even after immunoglobulins, even after Plex, even after rituximab, it may take time to see the effect and the benefit of those. And so walking them through that timeline, walking them through that their child will still have benefit from immunotherapies throughout a period. And it's not that they're going without immunotherapies. It's just that we're looking at a specific additional immunotherapy can be helpful. And then talking to them about some of the safeguards that we have within clinical trials in terms of potentially receiving rescue immunotherapy if patients are not showing improvement as we would hope, and some of those other safeguards to help them really understand the greater treatment sort of picture and disease course picture to help them make those decisions.
Amazing. Yeah, that point about the timelines, I think, is so important because otherwise, yeah, you're left in the dark. And I think timelines really help you kind of position yourself. Yeah, I think that's so important. Just staying on the topic of families, you have touched on this, but you have told me that you've described that trust and a strong therapeutic relationship is one of the most important factors in whether families feel able to even consider a trial at all. So, how do you build that trust with families?
Yeah, I think there's a few different ways that I try to do this. I think the first way is being involved early. So I don't want to just be someone coming in talking to them about a clinical trial and they have no idea, they've never met me before, or this is new. I'm fortunate that I am able to consult on these patients right from the get-go. So when we have a patient come in with a concern for autoimmune encephalitis, the inpatient team calls me. I'm able to go over and talk to the families. And I think that helps build a therapeutic rapport right from the beginning. I think it's very scary for families, obviously, to have their child ill and then have their child ill with something that is such a rare disease and that they have a really hard time understanding themselves, explaining to other people because they've just never encountered it before, most likely. And so when they are able to feel like, oh, there's someone who sees a lot of these patients or as many patients as possible, given the limited number and the rarity. But this is the person who sees all these patients here in this institution with this disease. I think that helps them feel like, okay, I've got the right team. And so that's sort of the first thing, is to really help them feel like we are a team, and that regardless of whether they're eligible for a trial or not, whether they enroll in a trial or not, I'm going to be there through this whole process. I think the other thing that helps establish trust as well is to just help them know. And I tell them from the beginning, I say, we're going to have lots of conversations about this. I'm going to give you some information now. You're probably not going to remember any of it because this is an incredibly stressful time. So we're going to keep having these conversations. And so just being really present that way. I also give them clear expectations in terms of and it's hard because every patient with autoimmune encephalitis is different. Every recovery is a little bit different. But I talk to them sort of about that timeline from the very beginning of, this is going to be, uh, we are going to see improvement, but it's going to take a lot of time, and that we're looking at recovery on the order of, you know, months to years and not days to weeks. Not meaning that their child's going to be in the hospital that long, but it's going to be a long course. And I think that helps establish, like, we're in it together, and this is the start of a very long journey that we're taking together. I think that really helps families have realistic expectations and not thinking that they're going to be out of the hospital in a couple days and it's going to be like it never happened. But also to know that they have someone who's going to be there through the process, I think helps quite a bit.
Wonderful. If there was one misconception about involving children in clinical trials that you'd like to dispel, what would that be?
I think the conception that or the idea that it's a high risk approach, so that clinical trials are risky. That's the risky option, is really a misconception out there because and even before I knew this before, but until I really jumped into the Extinguish trial, I didn't realize how many layers of regulations there are, how hard it is actually to get these trials approved for children because um, all the regulations and sort of safety monitoring that clinical trials require for adult patients, that's just heightened so much more in children. And so I think there is this idea that like it's very experimental, but it's again it's not that we're looking at, okay, should patients receive immunotherapy or not? It's what specific ones and or that these are untested drugs. These are drugs that we're pulling from other autoimmune neurologic conditions that are used in other autoimmune neurologic conditions, and we're saying, can we apply them to this? So I think there is that idea that there's that's like the riskier option to go, but really, I have these discussions like, okay, this is just another treatment option, and I'm going to describe it as the risks and benefits of each one. Here's the risk and benefit of this treatment approach. Here's the risk and benefits of this treatment approach, which happens to be a clinical trial. So I think in the face of limited evidence, it's important to have that conversation as like this is just one of the treatment options that we have, not as something like in this very different category of this like risky experimental treatment.
Looking at the future, if we were having this conversation 10 years from now, what advances would you hope to see in how we diagnose, treat, and study autoimmune encephalitis in children?
Oh, I love this question so much, and it because there's so many things I hope to see, and this is probably a question I could spend the rest of the time talking about in terms of different ways that I see the field going. It's interesting that you asked this because when I'm in the hospital and I'm teaching trainees and discussing the field of autoimmune neurology or discussing a specific treatment approach, with them, I often tell them that the way that I'm treating patients now likely won't be the same as I'm treating them in 10, 15, 20 years. And that, is not meant to be like a heavy, like discouraging thought, but more of an exciting and hopeful one that I discuss with them that I know that, we're doing the best with what evidence we have, but I'm very hopeful that in the future we have more so that we can do even better. I think we're entering a very exciting phase in autoimmune encephalitis of this sort of an era of prospective treatment trials. We no longer are going to be needing to just always rely on those retrospective studies, but we're seeing this forward motion of prospective trials, and once we start getting data from those trials, it's going to be really exciting to see how it takes the field and what information that we get from it. But I think if I can distill it down to sort of two main areas that I hope to see progress and change in over the next 10 years. I think the first would be really understanding how treatment approaches really impact outcomes for patients. So, we talk about it all the time that generally functional outcomes are good in children with autoimmune encephalitis, but there's still room to go. There's still some patients who have very significant neurologic disability for a number of years or even permanently. And so I think it's not like we've got it all figured out by any means. So I think I would hope to see some improvement in that area of understanding treatment approaches that might improve our outcomes from where we're at right now. Every time that I have a patient come in, with autoimmune encephalitis and I'm treating them, I always have these nagging questions in my mind of, do they need all these immunotherapies I'm giving them? Am I putting them at necessary risk for other complications because of all these immunotherapies? Do I need to be doing more immunotherapies? Do I need to be doing them earlier? Do I need to wait longer? There's all these questions that just sort of nag at me that I wish we had the answers to. So that's really what I'm hoping we can get to in the next 10, 15, 20 years is having a better understanding of those questions that all of us think about as we're treating these patients. So really hopeful for the prospective clinical trials that we're seeing now, and then that's just a launching board for even more. I think, everyone running these clinical trials knows this is not it. This is not going to be the last, clinical treatment trial and provide, the definitive treatment approach for the rest of time. But that there's a lot of other trials coming after this, which is really exciting. I think the other area that I hope to see improvement in over the next 10 years, and if we were having this conversation in 10 years, we could talk more about, is just in general talking about how we define outcomes. So as I mentioned, we talk about these good functional outcomes. But I see these patients improve, and that's why I love what I do, because I get to see patients. I get to know them as they progress in their recovery. When I see them in the hospital, I always tell families, I know I'm not meeting your child. I'm meeting, a different version of your child than what you're used to, and that's why you're here in the hospital. So it's really fun for me to see them and get to know them as I see them outpatient over the years. But I also see these things where parents are like, there's just some differences. There's some changes that are hard for them to describe or hard for them to fully understand when we talk about these outcomes and these outcome measures that we have. And so I would really like to see some improvements, and there's more coming out in terms of our understanding of long-term outcomes, in terms of how it affects development, cognitive outcomes, specifically in pediatric patients. But what I'm hoping to see is that we have a better understanding of those and a better understanding of how to track and manage those. So how are we assessing outcomes, not just in ways that are important to us as clinicians or we think is important, but how are we assessing outcomes in a way that's actually important to families and patients? How are we ensuring that we're capturing those aspects, some of those more subtle things like fatigue or sleep difficulties that we might be overlooking with current measures, and make sure that those are important parts of what we're looking at as well, because those matter day to day for patients. So some consistency in knowing what outcomes to measure, how to measure them, when to measure them, I think is a huge advance, because that really ties to my first point as well, in terms of wanting to see how different treatments may affect outcomes, is we need to understand what outcomes we're measuring first and foremost. So I think those are the two big main areas that I hope to see forward motion on over the coming years, and I think we'll get there for sure.
Amazing, thank you. And I love that answer because yeah, we're very passionate about outcome measures as well, and it's so important. And yeah, we're always advocating for that to be improved. So yeah, thank you for that.
Mhm.
Um, so yeah, we're coming towards the end of the podcast, and I was just wondering if you could tell us about your experience in enrolling pediatric patients for the Extinguish trial that you're working on.
Yeah, yeah, it's been a really great experience, both challenging and rewarding. I think I mentioned earlier there were some aspects of clinical trials that I understood, but not experientially until, I did I've been involved in the Extinguish trial, and just the challenges that there are with rare disease. So, studying autoimmune encephalitis and a treatment trial in autoimmune encephalitis is not easy, because capturing these patients. We all hear about stories of patients that have gone undiagnosed for times, and then we have to sort of capture patients at the right time of diagnosis, but they get those first line immunotherapies, but we need them to not have gotten too many immunotherapies. So there's really a window that we need to capture these patients in. So that's one of the challenges that's hard. I think another is just having these discussions. There's a lot of variability in treatment practices. So really having clear discussions with everyone involved about where the evidence is has been a lesson that I've learned from being involved, that's really important to involve everyone in those discussions, and have it really be a team-based approach. I think one of the things that has been really interesting to me about the extinguished trial that I didn't really expect at all, and that I didn't anticipate was how engaged and interested families are in helping move the field forward. Like it's always fascinating to me that in these moments of incredible stress and probably the most stressful times of their life, seeing their child ill, that even patients who are not eligible for trials, and I don't even discuss clinical trials because there's not one that they're eligible for, sometimes parents will ask me, is there any research that we can contribute to? Which is so interesting to me that that's what they're thinking about in this moment. And I've thought a lot about this and if it was my own child, how I would feel about these sort of things. And is that something that would, automatically come to my mind? Obviously, as a researcher, I think about it a little bit differently, but I think parents, I kind of alluded to this earlier, but I think they feel this sense of uncertainty and they read about things, they know this is super rare. They know that we need more evidence, we need more data, we need more research. And I think there's this huge feeling of wanting to help other families in the situation that they're in. And I think that's like an incredible thing that parents are able to see that and feel that in the moment when their child is ill, that they're thinking of others. And they often say to me, even if it doesn't, like if it's something that can help other families, I will do anything. We will contribute because if there's a way that we can help others in the same situation, we will gladly do it. So that's one thing that's been really surprising to me is just how thoughtful families are about that approach and how much it creates this sort of unified sense of like we all want to move the food field forward and this is how we're going to do it. So I think that's one thing that has been really exciting and great to see is just this sort of as this whole like team approach of like this is what we're all working towards this goal. I think the other thing that has been surprising to me is how it is sort of a similar type of similar to what I discussed, but is there's really this sense of community that the trial almost creates. Like these families sort of become part of the extinguished family, and I think they really feel that and they value that, and they probably because they have a lot of contact with, there's so many study visits, but they become really like, almost close with the study coordinators and it's really great to see that, they want to keep in contact with us even beyond the study. And I think it's really cool to see that. And I think, that's what we all want in this rare disease field is the sense of community because it can feel hard when you're the only clinician treating this disease at your institution, the only family who's been going through this, the only researcher who's working on this. Like, and I think that's what I love about the autoimmune neurology community is that we really strive to be a community with everyone because it's, that's what we need for this field. We just need to be collaborative and we need to be one big community moving this field forward.
Amazing. Yeah, the extinguished family. I love that phrase. That's going to stick with me. So yeah, Dr. Wright, we have come towards the end of the podcast, and I've finished my formal line of questions. And I was just wondering, before we close, is there anything that we have not discussed that you'd like to mention?
I think we covered a lot of the things that I wanted to discuss and mention. I would just say I really appreciate uh your interest in this topic. Of course, it's something near and dear to my heart as a pediatrician, and I get really passionate and excited about the idea of moving research field forward in the field of pediatric autoimmune encephalitis. And I think it's a really important discussion to have. It's one that we can shy away from or be hesitant to discuss about clinical trials in pediatrics and some of the challenges, but some of the benefits of it as well. And just because there are so many complexities involved in it, but I appreciate you having me on to discuss this, and I think there's some great topics for discussion that you brought up.
Absolutely. And yeah, thank you for that. And yeah, we're absolutely very passionate about this. Yeah, so yeah, Dr. Wright, thank you so much for sharing your time and expertise with us. It's been a pleasure talking to you today.
Of course. Thank you so much for having me.
And I'd like to finally thank you, the audience, for listening and watching and for dealing with the different pronunciations of encephalitis. If you have been affected by any of the issues raised wherever you live in the world, please contact our support services. Encephalitis International is here to help in whatever way we can to achieve our aim of ending death and disability from encephalitis. For all our information and support services, please visit encephalitis.info. And if you have found this podcast useful or interesting, please consider supporting our life-saving work by visiting encephalitis.info/donate. And for more podcasts, please like and subscribe. Thank you again, and see you next time on the Encephalitis Podcast.